Okay. Hello, everyone, and welcome to our webinar. Thank you all for joining us today. My name is Ziad Mahia. I'm the founder and CEO of Medical Circles, and I will be serving as a moderator today. We're here to explore a really exciting and timely topic, how artificial intelligence is shaping the future of remote patient care and telemedicine. As we all know, the landscape of healthcare is evolving rapidly, and AI is playing a key role in making care more accessible and efficient, especially for patients at a distance. Today, we have a fantastic speaker who's going to guide us through the innovations, the real world applications, and the impact of these technologies. Dr. Shahid Ali, a professor of digital health and innovation, founder and director of Dynamic Health Systems in the UK, consultant in cardio diabetes. He will be speaking to us today on this topic, which is AI and remote patient monitoring and telemedicine. Dr. Shahid Ali is an inspirational and experienced strategic clinical leader of large-scale change with a national and international reputation, and how digital innovations such as AI digital platforms, telehealth, and telemedicine can enable the transformation of health and well-being services to improve health outcomes in large populations. Just so everyone knows, the plan today is that we'll start to hear from Dr. Shahid Ali on the latest AI innovations in telemedicine. Then we'll have a short discussion and open it up for your questions at the end. Kindly note that to post your questions in the Q&A icon so we can see them to answer them at the end of this session. Without further ado, please join me in welcoming Dr. Shahid Ali to deliver this presentation on this very interesting subject. Hello, Dr. Shahid.
Assalamu alaikum to my esteemed colleagues. It's very nice to have the opportunity to speak to you all, and I want to thank yourself and also Suleiman for inviting me to come along and speak about this very important topic, which is all about remote patient monitoring and telemedicine, but now with AI. So the opportunity to be able to transform the way that we work. And I'm hoping that I will be able to share with you over the next 40 minutes or so some of the work that I've been doing and some of the work that's been done here and how we've been able to bring about change and enable the digital landscape to unfold, certainly in our area over here in the UK. And of course, there's a big opportunity for you, for Saudi Arabia, because I know that the plan and there's an ambition within the next 5 years to actually move digital significantly along. And remote patient monitoring and telemedicine and AI is going to play a significant role in that. So all of you who are listening today will no doubt be able to make a difference along that journey. And I hope to join you because I'd quite like to be part of that journey. I think it's very exciting and a really good opportunity. Just to say a bit more about myself, I've been a doctor in the NHS now for more than 35 years. I started out as a neurosurgeon, thinking I was going to do brain surgery, and then I ended up doing hospital medicine, and then I became a family doctor. And I've enjoyed different elements of all of my sort of medical work that I've done. But I've enjoyed family medicine the most because it's brought me closer to the patient. I've had the opportunity to be able to work with patients longitudinally, get to know them really well, and truly engage with them. And I'll be making a big point about that. I've also worked as a medical director, looking after a population of about 500,000 population where I live in Bradford in the UK, and then worked in the Strategic Health Authority, looking after a population of about 6 to 7 million. And then I've been a national clinical lead as well as this professorial appointment, which I ended up doing after I left the national team. But it's my firm ambition throughout the whole of that time has been, how do we enable doctors not to get burnt out? How do we enable people to work in a much more in a smarter way than we do at the moment? And how does the model need to change in order to be able to do that? And I've had lots of ups and downs, and I'm happy to share them with you. One I'll share right now, trying to do telemedicine consultations. I was the first doctor in general practice to start doing telemedicine consultations. And the Medical Defense Union said, Shahid, you can't do that because we will not allow telemedicine consultations because they're unsafe. And I had to actually fight with them to convince them that actually telemedicine consultations are very safe when you have the medical record and you have all the information about the patient and you can have a conversation with the patient in an appropriate way. So lots of, challenges, but challenges are there to be met, and that's exactly what we should be doing. I'm trying to get here we go. So what's the big clinical promise of AI? Well, really, it's about three key benefits. First of all, there's an ability to be able to engage with the patient and personalize care at a scale that's never ever happened before. We work one to one. A patient comes to see us and we sit in our offices, but the opportunity to be able to look after a population in a personalized way is a big opportunity here. Also, I mentioned clinician burnout. That's real because essentially people are having to work harder and harder and harder, and the demand is going up. And so clearly there needs to be a mechanism by which that can be controlled. And thirdly, of course, we need to improve outcomes and adherence to medication. And improving outcomes means being able to make better decisions, being able to optimize healthcare, and AI really enables us to do all of that. But I'm going to start here, first of all, because patient engagement is very close to my heart. It's something I've learned over the last 35 years that working with patients in an engaged way makes a massive difference to the way that the person actually looks after their own long-term condition, whether it's hypertension or diabetes or whatever it might be. But also equally, when you look at this graph on the left-hand side, you see that this curve continues to rise. And if you look at this one, which is about Saudi Arabia, so you've got a comparison of UK and Saudi Arabia, and all you see is that the healthcare costs per capita GDP are just simply going higher and higher and higher. And Professor Derek Wanless did this work in the UK. And what he showed was that if you engage with the patient, if you don't engage with the patient, it continues to rise. And if you start to engage with the population and you've got a fully engaged population, this begins to level off. So the only realistic way of being able to truly affect the way that we spend, on healthcare is to be able to engage the patient. Such an important big factor that he discovered such a long time ago. And I've been working to try and sort of get that into our national guidance and so on to make sure that people understand it. We have done. We've managed to do that. But it's a big change. It's actually a big change to think of engagement in that kind of way. Let's just take a vignette. Here's a vignette of Ahmed with his diabetes, and the population of Saudi Arabia is what, 33 million population, and a large chunk of those people have diabetes. I was actually in Saudi Arabia giving a talk at a conference all about how do we tackle diabetes because it's my area of specialist interest. And I just want to show you that if you have the system in place, AI can actually functionally work really, really well. So imagine that Ahmed's glucose has gone up. And we have developed Dynamic Healthcare Systems, has developed VitraCare 365, which actually has a conversational bot in it. So a conversational agent or a bot, AI bot. And it will ask the question, have you taken your medication? And check activity levels and so on and so forth. But more importantly, it will actually correlate the data. It will identify the pattern so that there can be a response back to Ahmed to sort of explain to him why his blood sugar has gone up. He may already know the answer to this, but I'm just explaining how AI actually works. So you have an automated personal action because I have been working with those patients and I've been responding in a particular way. And this is what NICE guidance says we should do under these circumstances. So there is effectively the automated AI is already dealing with that person by sending them a message to explain this is what's happened here. Your blood sugar has gone up. And this is the reason why it's gone up because basically you have actually missed some medication. And here's some information about how to continue taking your medication. The interesting thing to note in all of this is that it starts with data. And if you're having to analyze the data all by yourself and listen to the alerts and look at the alerts and have to work out how do we deal with this, that's not a very effective use of the doctor's time. And neither is it a good way of actually working, because before long you will not be able to concentrate on anything. So the opportunity here is that the AI does the analysis. And the analysis, obviously, you train the AI over a period of time, whether it's blood pressure, diabetes, blood sugars, etc., etc. But there's an analysis and then there's a personalized action. And if I have agreed that personalized action for it to happen, it will happen in that kind of way. And then there's a clinical review. So you can see that in actual fact, by by placing the right kind of tools around the individual, it can make a big difference to the way that the person interacts with their condition, but also the way that the doctor interacts with the patient. So here, in this particular case, we have shown that you can drop the footfall of patients coming into the surgery by 40%. You can improve the HbA1c, patient experience and outcome. So just by starting to work in a different way, you begin to realize that not only is the patient actually engaged, but significantly the clinician is working in a smarter way. So how does that actually occur? Well, the patient has an interface on their side. So there's a patient side, which is called the Peach portal. And you can put as much information onto that as you want to. So once they've created their account, they will be welcomed by a bot. The bot will welcome them. And as a doctor, you will have prescribed for them, whether they've got hypertensive, whether they're diabetic, whether they've got chronic kidney disease, cholesterol, whatever it might be, heart disease. Essentially, that information you as a doctor can prescribe, or whoever's looking after that patient can actually prescribe all of those knowledge bases to the individual. So all of that knowledge, including all the other knowledge that you might have for that particular area, it can have all of that knowledge in there, and it can be presented to the patient as and when it's needed. Medication reminders can be set up, lifestyle advice can be provided, mental health support, which is such an important factor. People are so incredibly anxious, and they ring the doctor. Oh, I want to come and I need an appointment with the doctor. They don't really need to be seen face to face, but that's the way that they're thinking because they're very anxious or they're depressed. And the chatbot interface here can be in English or Russian, or of course in Arabic as well, in any language. So you can get over this whole idea of not being able to present it in a particular language. And I think that having something like this for a patient means that they can actually ask a question and they'll get a proper answer from it, not from the internet, but from the knowledge bases which are contained within the AI, and it learns from that experience. So, for example, I've created a knowledge base which is on hypertension. So when the person asks the question, tell me a bit about hypertension, the bot will go to the relevant knowledge base, pull out that information, bring it back, and it will even say that this is based on the expertise of Dr. Ali, general practitioner, blah, 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 blah. So you can personalize the service that you're offering to your own patients, which makes a big difference. I know that in Saudi Arabia, you're set up in a very similar way to the way that we are in the UK. So this kind of working will be familiar to you. It's not something that is alien. And of course, you can add various other things. The bot can make your appointments. It can tell you about self-care. It can do a lot of other things, repeat prescribing, etc., etc. So the point I'm really trying to make here is that from one platform, you can actually have the branding for the particular area. You can also have a personalized health bot, and there are patient-specific features for each individual person. We're not to say everybody is different. For 20 years at least, I've been going on about this idea of, one size does not fit all. We have to personalize services. So this enables you to actually personalize services, and it's even linked to NHS login, which means that a person who has the NHS app, they can utilize this service through their NHS app. So that's the way I think that we can kind of link together. Now, this slide really tells you that patients are not the problem. So your patients are actually not the problem in terms of engaging with technology. I mean, most of them are using WhatsApp. Most of them are doing, speaking, having calls all the time, video calling all the time. And what we've found from the research that we have done is that the vast majority, that's almost what, 69, 70% of people are willing to engage in this way of working. The patient engagement is actually very high. There are, of course, a variety of different reasons as to why people don't engage. Some people, particularly the very frail, can't do it, but then there's always somebody around who can. So usability issues come into it. Lives too, just far too busy for me to be dealing with my phone. I spoke to somebody the other day who said, "Oh, we just don't want a smartphone. We just don't want to engage with technology." Well, there are people like that who don't want to, which is fine. You just have to work in a different way. And also, some people may be far too ill for them to be able to manage things, but other people can help them as well. So the point of this slide is patients are not the issue. Clinicians and a change in the system is often the biggest challenge that I've found over the years anyway. But in the way I work is that I have Vitracare connected to my System 1. And this basically means that I can see all the patients on there, which links into the same shared database. I can actually prescribe digital services from here for the patient. So say I have a patient with 3 different long-term conditions, I can prescribe all of those knowledge bases and the relevant information and everything else that needs to go for that. So say, for example, you're trying to prevent diabetes and you have a HbA1c, which indicates that the person is now pre-diabetic. Well, you can have essentially set up a diabetes prevention service, and I'll speak about that a bit later on, where the HbA1c, once it's detected, automatically you prescribe the relevant digital services to that patient. They get a record, Vitracare record, they start using it, and they immediately change their lifestyle, and the whole thing starts to improve. That's how you reverse diabetes, not simply by giving somebody advice and letting them go away for a year and then they come back again, have another HbA1c. It's about continually providing support, and that's what really makes a difference. This is all in Microsoft 365, and it utilizes Teams. Like we're having a Teams conversation now. Well, I can book an appointment in Teams for any patient I want to speak to, and have a telemedicine consultation for them. I can just do it through here very, very simply. It also connects to Power BI and Copilot. So I don't know whether you're familiar with you will be, but Power BI allows us to create charts, and Copilot has its own AI, which enables us to summarize data and pick up information as we need it. And also, in actual fact, it can take all the data that I can say, pick up all the data from all my hypertensive patients, display it on a graph, and show me which patients I need to actually contact and the ones that I don't need to contact. And it will even write emails for me to say, these are the 70% of your patients that you don't need to have anything. I'd say, okay, send them an email to say that everything is well. You don't need to worry about it. Continue monitoring as you are. You check your blood pressure at home. It goes into Vitracare AI picks that up, and we know what's going on with the patient. The ones that we really need to focus on are the individuals that really do need input, and that is where a doctor really comes in. It's not looking after healthy patients. A doctor comes in when the patient is not, healthy and needs an intervention, needs some support. And this is where the expertise and the personal consultation and everything else comes into its own. We use RAGFlag for content management, which means that in actual fact, just because somebody's hypertensive and they're diabetic and they're hypothyroid, all the knowledge bases don't get mixed up. They only get the relevant information that's needed for them. So if it's about a hypertensive issue, they only get the hypertensive knowledge. This knowledge base is not from the internet. It's knowledge bases that we have created, and you can create as well based on nice guidance and the way that you like to have the information, providing that you've got evidence-based way of doing it. So what am I talking about? I'm talking about what we're doing right now is the current state, structured, very traditional model, annual health reviews, virtual, or you can have telemedicine and in-person sort of options where people are coming in and seeing you. Very reactive way of working. Manually, you have to follow everybody up. And you can't really personalize apart from the consultation, patients coming in, sitting in front of you, and you hit off and you think, wow, we've got a really good, I like this doctor. And the patient says, I like this doctor. And the doctor says, well, I'm getting on really well with this patient. The model works, but it doesn't work in the way potentially there's massive improvement that can be made to that. And of course, that's shown in the future state, a dynamic patient-led model. And that's why I talked about right at the beginning that engagement with the patient is so important. This is proactive, is continuous. The person's got a mechanisms to be able to look after themselves more effectively, and they love it. Patients love that. Where you are actually as a doctor, and I've seen this over the years, and I've been working like this for years, where the patient actually, you say to the person, well, you really can set a goal for yourself. What is it that you truly want to achieve? And you'll be amazed at what people say, because if somebody wants to get into a wedding dress, they will lose weight. I kid you not. And the reason why they'll do that is because they are actually in control and they want to do something. If they really want to prevent their diabetes, they will. So, self-management tools really does help. Automated monitoring. You can actually allow for integrated care coordination. And of course, this is personalization at scale. Every single patient has got a personal kind of mechanism of dealing with them. And this is the biggest key thing, really. It's data-driven insight. So it's taking a massive amount of data and it's converting it into something which is actually useful. And why does that help? Well, it helps us doctors to be able to make easier, better decisions. Decision making becomes easier, and it speeds things up. It gives us greater productivity. It saves us time. So, and it stops us from burning out, which is also equally important. So this is kind of just an example. You can have a dashboard. You can set whichever dashboard you want, where you can have, I've got red, amber, green. So basically, you know which patients are doing well, which patients aren't doing well. You can pick out whatever you want, whether it's to do with their cholesterol, whether it's to do with their hypertension or diabetes or whatever. And then you can actually we'll select out all of those patients for you from the patient record, and you can decide what actions you want to take. And the more that you do this, the easier it becomes because you get used to working in that kind of way. So you're not having to see every single patient. I call this working by exception. And I've been calling it working by exception for a long time because not everybody needs to be seen. The well don't need to be just reviewed. What you really need to be doing is dealing with the individuals who are not in control, who actually need help. And I am talking not about acute consultations. I'm talking about, chronic disease management here. That's where I believe that this makes the biggest difference. So I mentioned to you before that we incorporate Copilot AI. And this really, like I just said before, gives you the data analysis and the summarization so that you got all of this big data being broken down, and it allows you then to be able to make interesting kind of observations from that and decide next your decision making. But that as the process continues, it actually learns. The AI actually learns your style. How does this doctor respond to patients, and what kind of language do they use? And it will even create emails for you, which are very specific in terms of the way that you like to speak to doctors, like to speak to your patients. And they will basically, the patient will read your email and think, well, this is actually coming directly from my doctor. And it is because you're taking that action that email should be going out. So I think another thing that Suleiman asked me to talk about was workflow optimization. And of course, I've just been talking about that, this key challenge of data overload and management at scale. So, without AI, I've just said earlier on that manual review of the patients is a problem, time consuming, documentation, blah, 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 blah. And then on the other side, you've got this prioritized, very actionable information and automate. You can even, it can basically take your clinical notes as you're having a consultation, although that's not something that's used widely right now, but it can be. In hospitals, they're beginning to start doing that. Intelligent alert escalation. This is really important where people are going off. So if you're monitoring them and there's a significant change, there can be alerts that really help you to be able to change the direction that things are going in. And management by exception, as I've mentioned before. So With AI, it's a game changer. It enables you to optimize and improve productivity like never before and enables smarter working. And now, improving patient outcomes comes out of all of that, what I've been talking about. So the personalized health and the engagement and the medication reminders, the tracking, et cetera, all of that, all of the things on there. These bots can do, most of this. And in actual fact, now we're really looking at how bots work together, or the actual these agents work together so that they're dealing with different aspects of things, but they come together and get orchestrated in a way that ultimately delivers even greater patient outcomes because they're all very specialized in what they do. So if one of these bots is symptom tracking, that's all it's doing. Another one might be providing mental health support, that's all it's doing, but it's orchestrated by another bot that actually manages all of this. So you can see the capabilities of these bots are endless. And I think that it will continue and develop and develop and develop further. As we begin to utilize this in healthcare systems, we'll begin to see a lot more change occurring. Just going to give you a few examples of some approaches that we've done at different in different kind of environments. So this is a case study in Bradford with the GPs in Bradford, where we deployed VitraCare, engaged patients, activated them into self-care. Even within a period of about 6 months, in the first tranche of 144 patients, HbA1c fell on average by 16 millimoles. Big change in blood pressure as well, reducing stroke risk and MI risk. Weight fell by an average of about 2 kilograms. This is not by adding medication. This is not by using injectables. This is by people actually engaging and changing their lifestyles themselves. So 40% reduction in contacts with primary care. So significant change in the way and the pressures which we deal with, which affect us as clinicians on a daily basis. Here's another, we're talking about telemedicine, so I thought I'd share this one. This was done in Lincolnshire, where people who'd had a cardiac event, and it was during COVID, when COVID shut everything down. So we developed a service which was all on telemedicine, and essentially it allowed the rehabilitation of these patients who had MI to be done at home. They didn't need to go to the hospital to have this done. And it was hugely successful from a patient satisfaction perspective because they didn't need to leave home, and they loved it. And they were all familiar with telemedicine, so it helped them as well. But the nice thing about this is it actually is a very good way of showing that you can deliver, just like I'm talking to you guys now, and you can see me, and I'm delivering this talk to you. Similarly, you can deliver all of these different interventions in this way as well. It doesn't mean that all these people have to go to the hospital, and the person who's there, the healthcare professional, has to deal with them in a very specific way. And I'm looking at how we do this with lots of other areas now, physiotherapy, a number of other areas where we can actually get involved in. So they're now training other cardiac rehabilitation specialists to train them up and get them to do the same thing in other areas of the country. This is something that I think that would be really interesting for Saudi Arabia, because it's all about diabetes prevention, and it's the Rewind program in London, and this had about 1.2 million patients, where they looked at people who were becoming diabetic or may have got all the risk factors to become diabetic. And we essentially arranged automated campaigns to them, and courses and subscription, and in knowledge sharing, really, to try and get them to modify their lifestyle. And it's working really well, because people are going less to GP consultations about this. We're beginning to see that change in London as well. So this is how you can actually deal with public health. And one of the biggest sort of my feeling about Saudi Arabia is that both, if we could deal with hypertension and diabetes in Saudi Arabia, the population would instantly become much healthier, because the numbers are so high, and the opportunity to bring about change is very significant. So I think being able to utilize different ways of working, digital ways of working, not always AI, can actually make a big difference as well. So I was asked to speak about compliance, not that I'm particularly an expert in compliance, but I think suffice to say that the in Saudi Arabia you have good compliance and regulation, and of course these are the three kind of pillars of clinical safety and data sovereignty and ethical and explainable AI and responsible AI. I think they're all very important. You've got that set up, so it's important for when you start working like this, and I'm sure that you will very soon, that you will begin to realize that actually um, the this is so essential, and it's essential because if you think about it, data privacy and consent is a given. Patients must know how their data is being used and is properly encrypted. But the also there needs to be clinical oversight. I'm not suggesting for 1 minute that AI is going to replace doctors. No, it's going to help us to work more effectively, and it's a tool for us, and that's how we should really see it. It's not. It should always have clinical judgment and oversight to make sure that things are being done appropriately and properly. And bias mitigation is another one. If the algorithm's wrong, the data is skewed, or humans are prejudiced in many ways if they don't like particular people or whatever, then that can also cause huge problems. So really important to make sure that that is looked at on a regular basis, and you look at the information, and then you make changes as and when you need to ensure that you are actually mitigating the bias. And patients are sharing very, personal sort of information on these platforms. So there has to be that kind of empathy and safety as well that goes with it. So responsible AI adoption is also equally very important. So I thought, I got the impression from Dr. Zaid the other day that, people really want to have a bit of a conversation to sort of learn what this journey was like. So I'm coming to the end of the talk really, and I wanted to just give you a flavor, and I wanted to give you a kind of sense of the positivity behind this, that you can make this happen. And if you do make it happen, Saudi Arabia will be a much better place in terms of health. You'll begin to reduce the spend on healthcare and also improve outcomes and prevent a lot of, disease. So AI allows this sort of personalization and proactive care, and we need to move to that. I've been talking about proactive care for at least 20 years since I came onto the whole personalization and patient engagement kind of agenda and recognized it was so important. And remember that it's not about replacing your clinical judgment. It's all about enabling us to work more effectively. I've said that several times, and I genuinely mean that. This is about, improving the system as a whole, um, and improving the outcomes for patients. So just the last slide, which is really a closing message that AI platforms amplify your clinical skills to deliver high quality preventative care for all. So we can do it. We just need to have a mechanism and have the wherewithal and the positivity to actually try and achieve that. I hope that's what Suleiman wanted and what Zaid wanted and what you were expecting. I'm happy to have a discussion and open up for questions and so on. And if I'm able to answer them, I will try my best to do that. So if I hand back to you then, Zaid.
Yes, thank you so much, Dr. Shahad. That's more than we wanted, actually. Such an insightful presentation. And you've highlighted some powerful ways, actually, that AI can enhance workflows. The biggest problem that we're having here is the amount of patients that we see for follow-up and so on. So what you just
Yes.
showcased is actually
Yeah.
would be beneficial for us as practitioners to reduce the load and actually take care of patients all over Saudi Arabia, not just patients who are able to come to the clinic. So
Yes.
I'm sure many of us are already thinking about how can we implement these ideas and how can it apply to our own departments and practices. So, before we open up for the audience for questions, I'd like to take a few minutes to explore some of the themes you brought up in a bit more depth, if you allow me. Um,
Yes.
First of all, from your perspective, doctor, or from your experience, sorry, what is the most impactful use case that you've seen that is safe to deploy today, and what requires, let's say, more rigorous study in the future?
Well, I think the primary care case for managing long-term conditions is ready, is deployed, is getting deployed across the whole of the UK in different PCNs now. So I think that's a good place to start because I would suggest that in Saudi Arabia, the right way to do this is if you can get the family practitioners on board and they understand because they're so pressured. I mean, the hospitals are pressured as well, but I think they're so pressured because they just have to deal with so much. So if you can get them on board in terms of recognizing that by using this, it's actually going to help to save time for them and make their lives easier and be able to manage their patients more effectively. I think that would be a good starting point. And the reason why I say that is because the way that general practice or your family medicine is constructed over there means that a lot of people are under pressure and they're interested to look at new ways of working. And once you can actually show them, and once you can actually demonstrate that, I mean, there's a lot of change within clinician comes from other clinician peers who've done something. There's this rule of thirds where a third of people are genuinely, ready to move forward, and a third see other people doing it, and then they do it, and then the other third they just kind of come along because everybody else is doing it now. So I think that raising awareness and getting people to realize that you can introduce that very, very rapidly and get that moving would immediately have lots of effects, not only on current management of patients, but also looking at prevention. If you want to do prevention at scale, family medicine is a good place to start. So I would say that, in my sort of experience, that doesn't mean that you can't do hospital outpatients or you can't, look at sort of population health from a public health perspective. But I think primary care, the way that primary care operates with the groups of patients and groups of practices working together, I think that's a good model to begin to introduce change and then scale it up. And it will work because once one set of practices make that change, others will follow.
Okay, thank you so much for that. Now, w- most physicians here are open actually to utilize other modalities to help them reduce the workload and also take care of their patients, especially remotely. But the problem is that applying innovation or innovative solutions require convincing multiple stakeholders in the organization.
Mhm.
So, uh, how was your experience in addressing, executive buy-in, and uh, what risks did you address, and how did you justify for the, let's say, upper management to convince them to apply these solutions to help us help patients?
Okay, that's a really good question because it has so many different ramifications. I don't know whether if you are I know you're familiar with the NHS setup, but the whole commissioning process changed quite significantly within the NHS. So trying to get for any company or anybody to try and introduce innovation, even though they say we're ready for innovation, trying to get that commissioned by organizations was incredibly difficult. One of the most challenging places to work when it comes to getting software or innovative solutions commissioned is within the NHS. So what you have to do is to be able to get the relevant people in the room. So over in the UK now, you've got ICBs. ICBs are so high up at the top, and they are just trying to deal with so much that they don't really know what's going on. On the ground now with general practice, we've got groups of practices, sometimes four practices, population of about 40, 50,000 patients. Some of them got population of about 100,000 patients. Speaking to them and showing them that, look, this is what you're doing at the moment, and this is what could happen. This is how this can change. And in actual fact, if I could just share with you here
Yeah.
this idea of digital adoption. You've got to have the relevant people in the room to be able to have that discussion, so that the person who's going to discuss with them needs to be able to be sufficiently qualified and sufficient of have understands the innovation to be able to speak to them and explain how that happens. So I go and discuss it with the relevant PCNs, or I have a discussion with groups of doctors and I share it with them and I say, look, this is what we've done over here. And I've even invited them. I've said, look, if you're interested, come and have a look at what we're doing, so that they can begin to understand, what is it, what is actually going on. And then you understand their resistance to change. Why don't they want to change? And then also, how do we incentivize it? Well, the PCN, they need to start working in a different way in order to save general practice, because everybody's finding it very, very difficult. You just mentioned exactly the same scenario in Saudi Arabia, where people are under a lot of pressure, too much information coming through, too many patients, too much demand. So in order to be able to manage demand, you can't just continue doing the same thing. So that you have to make that point. Something has to stop and change into something new. And it's about sort of showing them that, look, don't be scared of technology, because technology, there are some technology solutions which don't work, and if they don't work, then they don't work. But usually, if it's a good solution and you've seen it working, then there's no reason why, getting people on board shouldn't be a problem. And I think so. I think to answer your question directly, I think getting the risks that you face are that the relevant people are not in the room to be able to make a decision. So the decision makers need to be there. If you're going to talk about technology and you're going to talk about clinicians, the relevant clinician leaders and the technology directors and so on need to be there to have the conversation with them, so that they can understand. And they're going to make the decision, right? We will commission this, we will utilize this because of this, this, and this. And it's about making that case in a strong enough way so that people just recognize that they have to make that change. Uh,
Yeah.
so that's,
Yeah.
I mean, they're the kind of things that I'm talking about. And I've had personal experience where we've been to a number of different organizations, and some of them sat there and said, "Oh, well, does the technology work?" And I said, "Well, we wouldn't be having a discussion with you if the technology didn't work. And here I'll show it to you now so that you can actually see how it works." And then to be able to subsequently then go into the idea of, how do they want to try and deal with this issue? Because if they think that this isn't a solution, then what solutions do they have? And usually they don't have any solutions. So this is about getting people to understand that you can change. There is a mechanism of change, and getting the relevant stakeholders involved and the organizations and the relevant leadership involved to be able to buy into that. And that's probably the most difficult bit to do, and certainly more difficult here than in Saudi, I would imagine, in the
Yeah.
UK.
Yeah, no, no. Here we're totally open to change, honestly, and adopting technology in general. But in order to do that, we need like to justify it objectively, right? In terms of ROI, either cost
Yes,
savings
yes.
or readmissions, ER visits, and so on. So just to elaborate more on this point, so we can answer some questions that are posted by the attendees. But from your experience, objective results, in terms of objective results, what did you gain, like in terms of cost savings or true calculated ROI for organizations, or better health for the patient, other than the actual improvements of the patients themselves, so we can justify it, to management.
Okay, so we did a calculation once that we We actually managed to save almost £1,000 per patient per year by working differently, meaning that the number of appointments that they made, the number of the pharmacological products that they needed, say, for example, for these were in diabetic patients, the number of visits they made to the practice, the actual what else was it? We basically had a basket of measures which enabled us to then calculate, okay, how much are we actually saving per patient per year by utilizing this way of working in comparison to what we were doing before. Because not only are we improving outcomes, there's also saving in different ways. There's a saving in clinical time as well for the practice that's delivering that care as well. So there's a saving from that perspective. There's a saving on the medicines and so on that the individual is using, because if they're not needing more medicines, there's one particular bit of evidence I can share with you. In our practice, when we use this for patients with diabetes, the director of pharmacy specifically came to see me and he said, Shahid, what are you doing differently in comparison to the practices that are around here? If we look at your data for prescribing for diabetes, it's very different. You're using a lot less medicines than these practices that have got a similar population just around you. And I explained to him that this is what we're doing different. This is how we're engaging with the patient. They are actually actively involved in their care. We're utilizing a different method, a different way of working with them. So I think that return on investment is not simply it's a different factors that you have to take into consideration and the costs that are involved in that, and then basically put them all together and then say, okay, well, this is the cost saving to the system. The slide I showed you right at the beginning, which says that with engagement you start to save money, essentially that's where the saving comes, because when you've got engaged patients, they're less likely to use more medication and much more likely to, you're likely to prevent the disease, or even if they have the disease, they manage it more effectively. And that's where the actual return on investment comes in. You make the investment in the technology. The technology enables the patient, and that's how you make the savings. And we found it was about £1,000 per patient per year that
That's
we were
actually
making.
that's
And
actually amazing.
that's a
It's
huge amount of money.
yeah,
If you think that, you know, the spend of the UK sort of national spend on healthcare is about 130 billion, something like that. You
yes.
know, £1,000 per patient. When you begin to start having a saving like that, you're talking serious money. And I and not only is there a huge amount of evidence about all of this, in actual fact, I have personally over the years, over the last 35 years, I've been working as a doctor. I have seen that with patient engagement and all of these tools that we have for self-management, you transform the landscape, you transform healthcare. And I think that that's a message I'm trying to really get through to all of you. And I think that Saudi has a great chance, a great opportunity to be able to do that in the next 5 years. I think you can actually achieve it.
Hopefully so, and not just saving, costs, but actually saving lives and saving, the
Correct.
patient from
Yes,
extra, yeah,
absolutely.
suffering, right? So,
Yeah.
uh, okay, great. Now, if you'd allow me, Dr. Shahid,
Yes.
we would like to open the floor to answer some questions that are posted by our attendees. Um, the first question is, can we connect our in-house EHR system with Microsoft Copilot? If physicians rely on Copilot in their decision making, what are the final professional and legal, responsibilities associated with such decisions?
Well, if you connect a Copilot to say you're using, which systems do you use anyway in Saudi?
We use, there are local systems and there are multiple international systems, including Epic and Cerner, TrackCare and Best Care and so on. But we
Okay.
also have local systems.
Yeah, so I think if you want to connect Copilot in that kind of way and just connect it to your system, I'm not sure that I'm not sure that first of all you have to get permission in order to be able to
Yeah,
do that. Are they going to allow you to do that, to connect Copilot AI to the system? And secondarily, what would you do with it? Because we've connected it up and the with Vitracare, because Vitracare takes the same data that the clinical system takes. Okay,
okay.
so
Yeah, yeah,
but the difference here is that we have got linkage with Copilot specifically to do specific things. So therefore, that's how we utilize it. I think with the question that's being asked is, can we just link it to our existing system? It's not that straightforward. You will really need to speak to your IT department and also see whether that fits into your governance arrangements and whether you should or shouldn't do that. The second thing is this, that there may be some guidance in terms of whether you're able to do that in the first place anyway, right now in Saudi Arabia. Maybe that's something that needs to be looked at. Can AI systems be just directly connected up? Because there's a lot of nervousness here in NHS England about connecting and just utilizing AI just like that. So the AI system that we have and that Copilot works with is essentially very, very carefully controlled. Like I showed you the RAG, the RAG system that we utilize. The knowledge base is not coming from the internet. It's
yeah.
really
It's
actually
controlled.
very specifically crafted information and a knowledge base that we have created ourselves, and it's working on that. So I think this is a very good question, but it requires some looking into in Saudi Arabia in your own organization to see whether they're up for something like that. And I think you have to be very clear about what is it that you truly want to achieve from that. If you wanted to link Copilot and say, look, I want Copilot to record all my conversations with my patients and just have that in the record, I can check it and agree it, and that's fine. I mean, I actually think that's a good idea, and we can do that too. But I think that you need to get permission. So from a legal perspective, need to know whether your organization's up for
Yeah, yeah.
it.
The second question is, what mechanisms are in place to address risks associated with using AI when monitoring patients remotely? How are patient outcomes and patient safety monitored?
Well, this comes back to the slides I showed you earlier on, which were really all about
Yeah.
um, here we are. So this is how it's done. You have this compliance and regulation which actually manages all of that to make sure that things are done properly, and there has to be you have to have a process in place which is actually doing all of these things. The data privacy and consent and encryption has to be checked. Clinical oversight, is there somebody who's responsible looking at that? I look at all of that information to make sure that the system is operating properly. Bias mitigation, like I said to you, is really important. Does the algorithm work appropriately, and all the testing that needs to go with that? And remember that the large long language model, it learns more and more and more. The more data you bung into it, the more it learns, and so therefore that's why you need to revisit this over and over again. So and this is what responsible AI is all about. You have to have these mechanisms in place. So you have those mechanisms in Saudi Arabia. So whichever system is deployed, it's going to have to go through that regulatory system and compliance to make sure that people feel that clinicians and patients feel safe about it.
Um, Another question is, how do you monitor the success of implementing the model and avoid patient harm? I think it's related to the what we just mentioned.
So say that again, Zaid?
Yeah, how do you monitor the success of implementing the model, which is remote patient monitoring, and
Oh,
how do
right,
you
okay.
avoid patient harm? How do you,
Well, I mean,
yeah,
monitoring is essentially, oh, sorry, knowing the success of it. Success is all about you obviously looking to see how things have changed for you. You know, if you've got all of these patients that are now utilizing a different system, are working in a different way, then you need to collect some data. You will have data points. Remember that Power BI actually has a lot of is very powerful, really, in order to be able to break information down and to be able to show you a before and after picture. You know, this is a situation before, this is a situation now, this is how it's changing over a period of time. So that's how you'll be able to get the insights as to what's going on and whether you're actually making a difference. And remember the parameters for overall kind of outcomes for patients as a practice, the system that we use actually tells you, you know, what you're doing with every single patient anyway, you know, where you are, have you actually achieved the outcomes required? So you know where you started off, and you know in 6 months' time where you've got to, and then in a year's time where you've got to. So you can begin to then gauge, you know, what sort of improvement are you making over a period of time. So there's an element of research R&D that goes on hand in hand with the change that you make. That's the only way that you can. That's how you produce evidence, don't you? You have to really do a bit of research to produce the evidence to show that you've made a change. And secondarily, it's all about collecting risks and recognizing risks. Risk management, risks are always there with whatever you do. And as a medical director, when you know we were always talking about risk all the time. Half the time we spent talking about risk of doing this and risk of doing that. But risk mitigation is where you know where you are at. That's what you need to do. So it shouldn't stop you from doing what you want to do with the technology. You just have to think about how do you mitigate the risks involved and what processes and mechanisms and systems do you have in place to be able to be able to do that and do it effectively so that there is no harm or there is the harm to the patient is minimized. Well, I'll give you a very good example. I mean, you may have heard of this, but there was a case where the AI suggested that a patient should go and kill themselves and commit suicide. So
Oh,
you know if your systems and processes are not set up properly, and you know it comes back to this algorithm. So the algorithm that's in there because the AI is only going to do what the AI
yeah.
is told to do or what it's meant to do. So if you know you get to the stage where the AI is actually doing things like that, that's the last thing you want because that is clearly completely wrong and should never ever happen. And that is why you need to have these systems in place and make sure that it actually operates appropriately and keep rechecking it on a regular basis. I mean, we have technology people. I'm not really a technology person as such. I'm a clinician with an interest in technology and an interest in particularly in digital. And I've had that interest for a long time. But I have my colleagues who are super bright when it comes to AI. And they are the ones that kind of, you know, look after that aspect and that side of it and make sure we're all doing that with clinical input from me. So it has to be done in that kind of way. So these are the this is where AI has to be. That's why I call it responsible AI adoption. It's not irresponsible by allowing it to just go off and do whatever it needs to. You need to do it in a very responsible way.
I really enjoyed our talk, Dr. Shahid. I mean, the work that you're doing is really admirable, and honestly, it would help a lot here, especially in Saudi Arabia, since we have challenges in terms of patient numbers and follow-ups, and using such technology is really the future. I would just like to apologize to our attendees who have posted questions and we couldn't answer them. We only have 1 minute left. 1 minute left, and I would just like to take this minute, Dr. Shahid, to thank you on behalf of the Saudi Patient Safety Center and thank our audience for their active participation. And finally, as part of the Saudi Patient Safety Center efforts to provide you with timely topics and interesting speakers, would really appreciate if you would fill out the evaluation survey sent to your emails after the session. So, just concluding this webinar, I'd really like to thank you, Dr. Shahid, for all your insights.
It's a pleasure, and thank you very much for inviting me. I'll be delighted to work with you guys because I think Saudi is going to be a very, very exciting place to do this. So if you need my help or you want me to get involved, then by all means, get in touch. By the way, my email address is on here, so there it is. I've given you my
Yes.
personal email address and the one at work. So by all means, get in touch, and I'd be delighted to help out if I can.
Thank you so much. Thank you so much, Dr. Shahid.
Okay.
It was a pleasure.
Okay. Thank you very much indeed.
Thank you.